Good morning, good afternoon, good evening, everyone. Thank you for joining us from different parts of the world. My name is Yolande Andrews. I am the Key Populations and Human Rights Program Manager for NACOSA, and I welcome you to the NACOSA series of webinars hosted under the banner of the Amakhoe Harm Reduction Project. NACOSA is a networking organization working to build stronger, more equal, healthy, and safe communities free from HIV, AIDS, TB, and GBV. We do this by strengthening community systems, mobilizing and managing resources, facilitating networking and collaborations, and providing and enabling access to services through advocacy, learning, and sharing collectively. As we approach the new grant cycle for Global Fund in South Africa, starting the 1st of October 2025, we are aware that the funding environment has placed considerable strain on implementation arrangements, especially for key population programs. We remind all that substance use cuts across all demographics, gender, and ages, including intersectionality among sex workers, transgenders, LGBTQI+, and prisoners. There is significant evidence to show that harm reduction and opiate substitution therapy saves lives, prevents HIV, TB, and hepatitis, reduces overdoses, improves stability, reduces crime, upholds human rights, and is cost-effective. Without them, the cycle of drug-related harm, incarceration, and ill health will continue to undermine South Africa's health and justice systems. The NACOSA's program evaluation around its opioid substitution therapy program presented today will illustrate this further and why the current funding crisis places harm reduction programming at risk. And we have amazing speakers today to illustrate those points from the COSUP program, NACOSA, and the people who use drugs sector. But before we do this, just to say again that if you prefer French interpretation, please go to the icon and select that option. And also we do have sign language interpretation also available on screen, but also you're welcome to go into the channel and select it. All presentations from today, as well as the recording of today's webinar, will be made available after this webinar. So for now, we welcome you and ask you to just engage in the sections and also to be able to ask any questions you may have within the chat box. So let us start off first with really giving proper perspective on this. And how else can we do this? By showcasing a human rights video that was commissioned to represent the struggles and challenges experienced by people who use drugs, and specifically women who use drugs within our communities. Sit back and enjoy.
I was a drug addict starting from 2012 until this year, 2024. I was injecting myself, I was using heroin. I didn't even have hope anymore in my life.
You know when you feel like you're not a human being, you're treated like you're not a person or statistic?
With addiction, it's difficult. You know, when you are in that life, you are controlled by addiction. I find the job very fulfilling as a social worker because I've seen people coming from really, really, really dangerous and bad situations to becoming my colleagues.
What I do when I wake up in the morning, I think about this population and I figure that they have no support structure.
When you're dealing with people who use drugs, they are discriminated against, there's stigma around it. The biggest issue is that they get to be violated mostly, being denied services, being beaten.
The importance of harm reduction services to women who use drugs and young key populations, it's actually a right and a freedom to access these services. The main challenges that they face daily, it's actually discrimination, where communities reject them. Remember that women who use drugs are really discriminated against, and they go through so much trauma. You're seen as you're a mother, and everyone is expecting mothers to be perfect. And everyone is associating drug use as the taboo. Why using drugs as a woman? So if we have services like this that give them, a breather, that makes them comfortable to talk about their stories and to actually combat, the health and lifestyle that they go through daily.
By 2020, I found out that I was HIV positive. The life we live here on the streets, we get raped, like by people we know.
We provide counseling, HIV counseling to the community at large. We screen them for TB, we screen them for STIs, and then after that we link them to care to the facilities.
Harm reduction is used for prevention of HIV and AIDS and TB. We do HIV testing, we do needle distribution. With the needle distribution, we use that to prevent sharing. The community, when we distribute needles, they take it as if we are promoting that they should continue using drugs. They don't understand that it's a package. You distribute needles, but you will still educate them about the dangers.
Part of the program, we now have OST, which is opioid substitution therapy, whereby we provide patients with medication to help reduce cravings and withdrawal symptoms if they had not used heroin. And by that, we try and win them off the heroin.
We started when there was no treatment, there were no ARVs, and we became part of the solution to provide professional counseling. So as a project, we meet the needs of the community as they arise. And it is our dream that we impact our community and we see change, as we have seen the change in the past.
We build a relationship that lasts. It's not a once-off relationship. You come to the site, they will come, even if they're no longer receiving our services, they come and greet us, they come and check on us.
So communities need to support them, communities need to understand their journey, communities need to understand their choices, and communities need to understand that they are not different from an ordinary person who doesn't use drugs. So that you can hear the story behind, because we all have stories to share. We all have journeys, we've all lived.
In 2026, you are waking up. Where are you waking up? What do you see?
I'm waking up in my own house with my family, my little sister, and going to work every day to go help other people, working to give others the life that I didn't get, so then they can get a better life.
Once again, just thanking, our partners, Anova, Tinswalo, as well as Rofe Community Center for supporting this video being produced. And NACOSA, as one that is managing a harm reduction program in 8 districts, is incredibly honored to have our speaker with us from COSUP, a model that should really be showcased nationally and globally as it works with, domestic resourcing. We have Dr. Bhoora from COSUP. Dr. Yuvisha is a specialist family physician with the University of Pretoria, where she provides clinical oversight for the community-orientated substance use program known as COSUP, and currently serves as acting program or project manager. She works at the forefront of harm reduction in Tshwane through COSUP, where she combines evidence-based practice with on-the-ground community evidence-based engagement. She has presented widely on national and international platforms and published in both local and international journals. Passionate about advancing harm reduction and substance use, Dr. Bhoora is committed to creating inclusive health responses, driving new research opportunities, and capacitating students and professionals to strengthen the field. Dr. Bhoora, welcome.
Thank you so much for the introduction, and thank you for inviting me to join. Okay, please confirm that you can see my slides.
Thank you, Doctor. We can see your slides. You may proceed.
Thank you so much once again for the introduction. I just want to set a timer so that I can also time myself and not go over time. Okay. So the areas of focus for my talk today will also be to discuss the COSUP model, to discuss the public health benefits of harm reduction and OAT or OST. We will look at how scaling up of harm reduction and OST is critical, and then also look at some of the challenges or concerns. So just a little bit of background information. The Community-Oriented Substance Use Program is an initiative between the City of Tshwane and the University of Pretoria, specifically the Department of Family Medicine. This is an important collaboration because it is a service delivery and research-based collaboration between an academic institution and a municipality, where the municipality serves as the founder and the university as the implementer. Of note that COSUP is the first and currently only state-funded harm reduction program in the country. So a very brief sequence of events, because very often we get asked, how did it come about that this relationship was developed? So in 2013, there was a memorandum of understanding that was signed between the city and the university. And this memorandum was with the intention that it should strengthen future collaborative efforts and develop a working relationship. And this built the basis for what would become the COSUP MOU. In 2015, there was a study that was conducted on substance use in Tshwane, which showed that the current interventions that were being implemented to manage substance use were not adequate due to poor planning, poor indicators, and poor implementation. These findings were then presented later in 2015 at a drug and substance abuse summit, which then culminated in the city requesting the Department of Family Medicine to put forth an evidence-based proposal that would develop a community-based intervention that manages substance use in the community. At the end of 2015, a harm reduction proposal was accepted, and middle of 2016, the first SLA that was signed, and that is how COSUP was born. So currently, we have 16 outpatient sites in the city of Tshwane, if you are familiar with the regions of Tshwane. And of note, 6 of our facilities are located within public health facilities. And this is very important as we talk about integration later on. Important to also note, as 10 of our sites are based within community structures, so for example, NGOs, churches, other organizations that we've developed relationships with. The services that are provided by each of our sites include medical examinations and treatment where possible, opioid agonist therapy, mostly in the form of methadone. We also provide a needle syringe service, HIV testing and referral to care, TB screening. Hepatitis C currently is only implemented, and linkage to treatment is only available when it is linked to a research project. And so we're very passionate about collaboration with other organizations and other academic institutions so that we can access services. So just to give a very brief summary, 15 minutes is not enough time to share all the programmatic data. However, just to give a brief overview of our last financial year's statistics. So we had on average 859 clients on OAT per month, with an average of 22 new clients that we initiated every month. Our retention rate, which is not shown here, remained at about 73% for 6 months, which means clients who were started on OAT remained on the program for at least 6 months, so 73% of them, which is actually very good when working with a difficult to reach population. Our NSP distribution and collection. So we've had more than 30,000 NSP visits over the past financial year, and we've enrolled just under 1,000 new beneficiaries into the program over the last year. Okay, the psychosocial services that are provided. So I should preface by saying that each of our sites is staffed by a supervising or supporting medical doctor or family physician. We also have a clinical associate, social workers, care coordinators or community care workers, peer educators, and data capturers at each of the sites. So the psychosocial services are largely provided by the social workers, and this comes in the form of screening and brief interventions, where we use the ASSIST, the WHO ASSIST tool, as a screening tool. Motivational interviewing is done, and then brief interventions are based on the ASSIST. So the social workers would develop individual development plans, and then counseling in the form of individual or group counseling sessions is offered to clients. We also do a lot of family support groups, and as the client progresses through the program, they are also referred for skills development. The skills is done in collaboration with community stakeholders, including other partnering organizations who are also working in the PWOD space, as well as in the key population space. Recreational activities that we try and offer at the sites include different types of games, including board games, outings, sporting activities, yoga for relaxation, and a book club. So most of the sites have a book club. The book club also participates in competitions, regionally as well as provincially. So other services that are provided include outreach. So we're very passionate about outreach, and it is also one of our major key performance indicators. Our outreaches are divided into universal outreach as well as targeted outreaches. And in a lot of these outreaches, we partner with other community-based organizations and other stakeholders so that the effect is much larger. Many organizations provide differing services. So with the larger universal outreaches and campaigns, we partner. Our targeted outreaches, we do focus on street medicine, which I'll discuss a little bit more in detail. And then we also provide outreach and services at the homeless shelters in the city. What makes the program unique is our university affiliation. And so this really offers us an opportunity to do a lot of training. And the training is not just at community level, where we are training community members and stakeholders around harm reduction and the services that we provide, but it includes undergraduate and postgraduate training of students within our institution, as well as within our colleagues in other academic institutions. We also provide training to professionals at health facilities, and we've also done training at Department of Correctional Services, providing education and demand reduction strategies at schools, and also involving faith-based organizations within the program as well. And so the collaboration specifically with universities is extremely important because it offers researchers, students, and the different faculty first-hand exposure to COSUP's work. This then supports research as well as evidence generation. And we know that we need to add to the growing body of research with regards to harm reduction so that we can build a robust database to support the interventions that we are providing. By exposing the students and the faculties to the work, you create a pipeline of future professionals who are sensitized to the realities of working with a vulnerable and marginalized population. And you hope that they would be able to provide the same line of services without stigma, without judgment, and also have a deep understanding of harm reduction in a setting of working with people who use drugs. Helping these collaborations also help us to strengthen our relationships with institutional organization, which I'll explain a little bit more as we go on. I mentioned the service delivery. So when looking at our research outputs, we have different types of research activities. So COSUP research specifically, partner-linked research. We have a lot of master's and PhD students completing work with us. We contribute to Secendo data. We have monthly internal and joint calls with our colleagues at the city, and all our publications are stored and available publicly as well. As part of research activities, we try to contribute to, and not just attend, but we try to contribute to conferences as well as learn from these conferences so that we can implement best practice standards as well. I mentioned street medicine, and I know that there are a lot of organizations that provide mobile outreach services, which is also a form of street medicine. But in our setting, it's a little bit unique as we are not equipped with the specific mobile healthcare services equipment. So we use what we can in our setting to still provide these medical services. So if we look at street medicine as a specialized field of healthcare that provides medical services directly to individuals, not just those who are homeless, but anyone who is using in their environment. And this focuses on delivering low barrier care to people who would otherwise struggle to access healthcare. So in our setting, our sites identify specific hotspot areas, and then we plan targeted activities aimed at providing services in these areas. So our peer educators are instrumental in assisting us in identifying these areas. So the services that we largely provide are wound care, screening for infectious diseases, as well as mental health services, needle and syringe information sharing, linkaging to services, linking to OAT, providing information, and where possible, psychosocial services such as help obtaining IDs and social grants as well. So the reason I wanted to highlight specifically the street medicine statistics is because while we're doing all of this, and while there are many organizations as well providing these services, we see major gaps. So if just to give us an overview, between January 24 and June 25 this year, our teams conducted 253 outreaches, targeted outreaches, where we saw just over 3,800 individuals, where we averaged around 200 people per month. And despite all the interventions, despite the sites that provide needle exchange, there's other organizations providing needles, we still found that abscesses were the most commonly reported complaint. And so why is this significant? It shows us that there are still high levels of risky injecting drug use that's occurring, and whether this is due to accessing, whether people do have adequate access to clean injecting equipment and proper knowledge of safer injecting techniques is unsure. But we know that there's a gap. If these complications are still occurring, it means more can be done. We know that untreated abscesses can rapidly become complicated, leading to more serious complications like amputations and systemic sepsis. We know with high levels of risky injecting use that the transmission of HIV and hepatitis C is accentuated. And so this really does highlight our unmet social and medical needs. Despite our intervention, this reflects that there are deeper environmental, structural, and healthcare issues, and it highlights that we do need to do more, and there's a need for additional integrated resources to effectively reduce the morbidity associated with substance use. The public health benefits of a harm reduction program are well known. These are not my opinions. These are based in evidence, based on research. So we know that one of the benefits is reduced disease transmission. We know that health outcomes of people who access services improved. We know that people will then have better access to care with programs around. And we also know that this will lead to a lower burden on emergency services. If people access primary healthcare services and prevent complications, they are less likely to visit an emergency setting. Interventions like street medicine also prevent an overloading of a public health service in terms of clinics. By providing a safe area for clients to dispose of their used equipment, it does enhance public health safety, and offering programs that are user-friendly, non-judgmental, promotes dignity, reduces stigma, and these initiatives really foster trust and engagement in care. So to ensure that we are able to continue our service delivery, it's very important for us to leverage our partnerships and diversify our resources. So we really rely on our strong relationships with public health facilities, with other academic institutions, and our community-based stakeholders. This allows us to unlock access to shared infrastructure for them to provide clinical support, and generally to use in-kind resources that enhance our service delivery beyond what is covered by our core funding. So we actively seek out and secure supplementary funding from other sources, including research grants, donor organizations, and other academic collaboration. And this allows us to expand specific components that are not always covered by the core funding. So if we look at the value added by doing this, by diversifying our resources and leveraging them, it multiplies the impact of the core investment. And this allows us to do more with less. And we still need to maintain the high quality community-based care, even in the face of constrained funding environments. If we have to make a case for sustainability and for continued support, we have to protect the value that's already been created through years and years of investment. The trust, the relationships that have been built is important to ensure continuity of care for this highly vulnerable population. However, in order to continue services, in order for the program to really meet its target, to reach the areas that we are not reaching, it's very important for us to support a structured phased transition that ultimately we want to integrate within the public health system. Initially at a municipality level continually, but ultimately the goal is to integrate within the public health system nationally. Thank you.
Thank you so much, Dr. Bhoora. I do appreciate your presentation. I think it was very practical examples of what we can be doing with domestic resourcing. I just want to check if there's any questions. I'm not noting any questions in the chat, but we're welcoming anyone that would like to raise their hand to ask particular question of Dr. from COSUP. Okay, doctor, I'm not noting any hands, but if you know me as well as I think you know me, you always know that I'm always up for a conversation. I think that, I particularly liked your last two slides that talked about sustainability and that talked about value add. And I think that this is something that constantly comes up about how expensive opiate substitution therapy programs are, how expensive harm reduction programs are. And truth be told, they are relatively expensive. But what is your take on it when you assess it or evaluate it against the greater impact to the public?
So very many conversations I had around substance use management, and very often it does take us back, conversations that are always asked, but what is COSUP doing to prevent substance use, to prevent the complications? Because yes, it is costly. OST is costly, providing needles is costly. However, if you look at the complications of not managing substance use, even from a user perspective, the cost of treating complications in hospital is a lot higher. The cost of providing ARVs for a lifetime is a lot higher. So while preventative strategies are extremely important, they are also difficult. And I didn't mention it here, but COSUP also does a lot of preventative activities. We can't ignore the fact that we do have a large number of people who do currently use substances. And so in that population, we do have to prevent the complications of substance use. And so in that setting, it's extremely important to provide services that are going to prevent further costs to the healthcare setting and enable the people who do use drugs to make healthy, informed decisions about their substance use. So if you're looking at it from an economic perspective, while it is expensive while it's implemented, if you look at the greater cost on the healthcare system, it is definitely a cost saving. So providing needles is a lot cheaper than providing direct acting antivirals that will treat hepatitis C. Providing needles and OST is going to be a lot cheaper than providing a lifetime supply of ARVs.
I couldn't agree with you more.
Thank you. And then the other thing is hepatitis C is something that a person can become reinfected with. So it's not just a once-off cost. If you look at the complications of hepatitis C, then you're looking at cirrhosis or cancer. So you have to look at the cost of treating the complications. How much does it cost for a liver transplant? How much does it cost to treat cancer of the liver? And then if you compare those costs to what it costs to run a harm reduction program, I think you will see that it's a cost saving.
No, for sure. I think one more question from my side is that some of the points that you made earlier, and we had individual Stacy from Stand, who's just done a study or a survey on the PEPFAR cuts in terms of key population program. And she's indicated in the chat that one of the recommendations is the expansion of the COSUP model. So, but you've also made a very good point in your last slide, which is, a transition to public healthcare, facilities or DOH management. So let's talk about that a little bit. What would it take to see an expansion of the COSUP model within other municipalities? We know this is possible. We know that can happen. But what would it take for that to happen? And then turn it around. When we talk about sustainability, what would it take to actually have this under the umbrella of Department of Health in our primary healthcare facilities?
So we are actually in conversations about that very discussion all the time. If we look at COSUP specifically, and like I mentioned, the university municipality link, it is definitely possible within all municipalities, I think. There needs to be political will, but I think there also needs to be an understanding of harm reduction and management of substance use from the university perspective. So if something like this were to be rolled out, say municipality-wise, there would be a lot of training that is needed at universities level, and that is totally possible. Academic institutes, that is what they do by nature. We train, we learn more. So there has to be an appetite for learning more, learning different interventions, and then partnering with municipalities to provide these services. I can't see why, if we could do it, other municipalities can't do it. The biggest thing I would say around nationalization, and if you're aware, then you know that there is a national pilot of OST that's being implemented. It's going to start. However, it's a very small pilot. I'm hoping that will inform future policies, that it can be done at national level. Currently on the essential medicine list, OST or OAT is only registered for inpatient use for the withdrawal management. So conversations need to be had about how to move it to primary health care. I'm hoping that the pilot will inform policy and at least get that conversation going. So I think the biggest thing is initially there was no conversations. Then there were conversations. Now we're in the piloting phase. So it does look like progress is happening. So we have to constantly advocate for it.
Thank you so much, Doctor. Just to say, there is one or two questions in the chat that you're welcome to answer. And just to articulate as an advocate myself, I think enough conversations have happened. It's now time to see actual implementation. We know through the COSUP model where it's been implemented in primary healthcare facilities that it is possible. We know from our City Ben and City of Johannesburg experience under Global Fund that it is possible to integrate it within primary healthcare. So I think from an NACOSA perspective, we're saying we want to start seeing some actions now. But thank you so much, Dr. Bhoora. We appreciate you. Please look into the chat for any questions. We're moving on now to the next presenter. And the next presenter will present on the program evaluation of the NACOSA Opioid Substitution Therapy Program. The speaker is Kalvanya Padayachee from NACOSA as the PWID program specialist. Kalvanya is a public health specialist with over 10 years of experience in harm reduction, HIV prevention, and psychosocial support for marginalized communities. She has managed South Africa's pioneering harm reduction program and now is a program specialist at NACOSA's Global Fund program for people who use drugs, implemented across 8 districts in South Africa. Passionate about human rights and evidence-based interventions, she bridges this policy and grassroots action to advance health equity and social justice for vulnerable populations. I would like to just express that this program evaluation was undertaken by Sediba. I'm perhaps pronouncing it incorrectly. Sediba. So we'd like to share our appreciation for Sediba in terms of the work that they've done across the districts in coordinating the evaluation of this program. Thank you, Kalvanya. Over to you.
Thanks so much, Yolande. Good morning, good afternoon, everyone. As Yolande mentioned, I think before I begin presenting the findings, I just want to check if my presentation is being flagged. Because I can't
see
the
slide.
So
we can see your presentation on the screen.
Okay, awesome. Yeah, so as I was saying before I present the findings, I think it's essential that we acknowledge the extensive team of people and organizations that were part of the evaluation study, and this would not be possible without them. So first and foremost, our deepest gratitude goes out to the lead authors and researchers who designed and really drove this work. Elaine Seaman, Vanessa Hutchin, and Sarah Day, as well as the entire evaluation team, which is mentioned on the slide. I also just want to give thanks as part of the study, the steering committee, to extend our thanks, who were part of the evaluation. Dr. Andrew Scheiber, who served as an independent consultant, the National Department of Health, Sonke Youth Forum, SANAC, and SANPUT. And then lastly, in terms of institutional support, Sediba Hope Medical Center and the University of Cape Town. So going straight into the goal of the evaluation. So this evaluation aims to assess the acceptability, accessibility, and affordability, and the availability of OST. It seeks to explore the progress and the quality of the OST program in order to make recommendations to strengthen the program in the next funding cycle. And the objectives around this was profile OST beneficiaries, number one, and document their results as part of the data. Access factors and program elements which support or deter OST accessibility, uptake, and retention, to access resource and requirements and overall utilization of the program, access whether the OST program has achieved its intended outcomes, and to access the quality of the OST program. If we move on to the next slide, we talk about the target population and the design. So this evaluation utilized a quota sampling approach, which is a type of purposive sampling to ensure representation from all relevant stakeholders, including clients. The study focused on individuals who are currently receiving or who had previously enrolled in OST, including those who became lost to follow, but were still engaged in overall harm reduction services. The exclusion criteria required participants to have used illicit opioid at least once or engaged in OST program recently or in the past and had to be 18 years or older and resided in the OST catchment areas and provided obviously informed consent to be part of the evaluation. And then the sampling quotas were based on the programmatic data from the Global Fund program from 2019 to 2022, and then 2022 to 2025, covering both existing and new OST sites. The data helped determine the sample size quotas, which was based on the patient load and high transmission areas with a 95% confidence level. The target population included both people who inject drugs and people who smoke drugs in Johannesburg, Cape Town, Ekurhuleni, eThekwini, and Sedibeng. We move on now to the next slide, which really talks about the program beneficiary profile of the OST program. And out of the 53,381 registered beneficiaries across the program, 2,046 were OST beneficiaries. We had 78% unemployment rate, 58% informal housing, 56 reported being single, 86 to 93% were male with the mean age of 33 to 36 years old. In terms of their risk factors, you would see we had a very low risk factor, around 3%, a medium risk factor, around 92 to 93%, and a high risk factor of 4 to 6%. Moving on to factors that were affecting the OST accessibility, uptake, and retention, which was part of the objectives which I mentioned. So based on the access, which is what gets people in the door, there was over 90% of the beneficiaries found that the key factors were peer educators for their initial access. So looking at peer educators is a crucial component to getting people onto OST or engaging with beneficiaries. We had staff reliability, so there were 96% that highlighted consistent and reliable staff as essential to easy access and staying on treatment, which talks about treatment adherence. And then community sensitization, also a major factor to improving access to services. On uptake, really just what encourages people to stay on treatment. And we know that there was a combination of internal motivation, so your personal readiness, as well as your external support drivers, which is your support from the program teams, which is your psychosocial interventions through your social workers and psychosocial counselors. There was critical external support that was included, which is your social support, your access to your overall access to services, and your peer-led outreach and education, just taking services to where clients are at. And then your community engagement and your right-based services were extremely fundamental. And then in terms of for retention, what makes people stay on treatment? And I think the top challenges that were part of the evaluation were the staff safety concerns, and a lack of staff support as part of the findings. We had systematic barriers such as clinician capacity, community resistance, and patient mobility were significant hurdles. And then for client level barriers, which included your transport, your fear of judgment, and managing OST side effects. If we move on to the next slide, this really talks about your outcome indicators. And we found that there has been a reduction in illicit opioid use. So nearly half, which is 46.3% of the beneficiaries, achieved a complete abstinence, while there was an additional 11.3%, which greatly reduced their consumption. And there was 30% that reported reduced cravings, 31% had their reduction noticed or reduction used noticed by others, which is their support persons, their family members, program staff, etc. And noting as part of the evaluation, there was a shift between other substances like methamphetamines and cannabis in some cases. There also has been improved social functioning. So 67% of the support persons reported major improvements in beneficiaries' daily living. Beneficiaries were finding jobs through our economic empowerment programs. They were returning to their education. They were showing an increase of stability while being on OST. And that is like really accessing overall healthcare services, whether that is ART, DAAs, TB medication, etc. In terms of their family and communities, there has been reports of improved family dynamics, restored dignity and positive social interactions. We've also seen this progress as part of our Sibambisane parenting program and our Bridges of Hope program, working with young people who use drugs that were on the OST program. And then beneficiaries wanted more psychosocial services activities in order for them to stay engaged within the program. And then in terms of overall holistic care, there were clinicians that were provided comprehensive healthcare services amongst during OST visits. So it wasn't just come in, drink your methadone and leave. It was conversation with the doctor. It was conversation with the nurses that were on site. OST, so we found better adherence in the program, where OST supported adherence for critical treatments, like I mentioned, ART, TB, medication, STI treatment, and DAAs. There's a documented reduction in unsafe injecting practices, which was noted, and then the program improves health literacy and health-seeking behaviors overall. And then lastly, in terms of the quality of life, on this slide, there was a combined 98% of the beneficiaries reported some level of improvement when it came to their quality of life. Reports of enhanced health, reduced anxiety, and a new sense of stability. And really that's through the psychosocial support services that were offered in collaboration with the OST. We had patients that were freed from the cycle of obtaining drugs, allowing them to focus on family, work, and regaining themselves as a person. There were some challenges that remained overall as part of the outcomes, which was they still faced stigma, they still had housing stability, and they still had difficult relationships with members within the community. In terms of the overall quality of the OST program, so I think I've mentioned a lot of it, but the OST program was highly effective. However, still faced a significant systematic and operational challenges that impacted the overall quality and sustainability. So we had beneficiaries that reported very positive experiences, specifically praising your peer support, your reliable staff, consistent availability of OST, which is extremely important. The program also successfully identified and initiate treatment for large majority of people. So if you look at the findings there, we had 83 to 89% that access services, while 88% were initiated into treatment. And this effective retention really demonstrates the strong 12-month mean retention rates within the program. They've also indicated, in terms of the successes and strengths of the program, flexible dosing. So we used a combination of supervised and take-home doses, which was 35% of the cohort that was part of the evaluation to support these clients on their journey of being on OST. There has been some key challenges and gaps, as I mentioned in previous slides as well, where stigma within the healthcare and the lack of OST awareness within law enforcement as a major issue, leading to doses being confiscated and a lot of treatment interruptions when clients are being detained or arrested. There was also a significant lack of individualized treatment plans and inadequate integration of mental health services, which we see now as OST services progressed. Clients also, communicated around transport. It's been an issue. 47% requested assistance with transport. And despite the program assisting with transport reimbursement, there was a lot of clients who listed it as a barrier, because we could only support a certain amount of clients with the budget that was available. And then in terms of the overall structural gaps, there was no OST access to correctional services when clients were being arrested or detained. And then in terms of the beneficiary request for improvements or economic support, was top of the request, 55% for economic empowerment and skills development for assistance while being on OST, and then more psychosocial support. So clients wanted more of a group session. They wanted more activities to keep them engaged, to keep them onto the program. And that was 39% that mentioned that. And then lastly, there was a clear need for help in terms of transport and shelter, which was 24%, which I've indicated. And then my second last slide, which is just talking about the overall findings. So just to note that this evaluation revealed largely a positive impact on the OST program. The key positive of the program was a significant heroin reduction, which is 43.3% reporting complete abstinence, and it improved social functioning. The OST program not only demonstrated positive health outcomes through improved health-seeking behavior and linkage to care, but 64% of the beneficiaries reported significant quality of life improvement. And I think I've mentioned it, so many times across this this evaluation, that we've just seen an overall improvement of quality of life. Between 68 and 85% of the cohort tested for HIV. We had a 25 to 45% HIV prevalence. 64% of them were on ART, 24% virally suppressed, 66% mental health screening, with a 42% being counseled for depression. 70% of the cohort was screened for TB, and 1,739 hepatitis B tests were done, with an 89% HPV vaccination and 1,632 hepatitis C screenings. I think also noting from the overall findings that peer support and staff reliability were vital in terms of access, overall access to OST services and adherence support. And while we understand that client motivation and social support drive OST uptake, there was a lot of challenges that have been experienced by clients, and clients are still experiencing, around stigma, discrimination, and policy barriers, which was cited as 12.6%, which hinders your OST overall implementation and limits treatment access due to these resources. There was also your geographic concentration. So as I mentioned, as part of the study, clients had to be recruited within the district geographic basin. So there was 11.8% that indicated as a restriction to access services within the program. And then inadequate dosing and limited understanding of long-term treatment can lead to suboptimal experiences. So there are transport limitations, again, which I've mentioned, 38.3%, and program-related changes, such as the OST side effects, which is 20.6%, fear of judgment, 8.6%, that hinders overall retention. And then lastly, your staff shortages, which was 34%, which really impacted around high staff turnovers within the program, and then your peer training gaps, which limited the program's overall capacity. And then my last slide, which is just around a call for action. And my call for action really is around, and which is something that Dr. Yuvisha also mentioned, is an integrated OST into a public healthcare system. We all on this platform, whether you're in a harm reduction space or not, have to advocate for a full integration of OST into primary healthcare services within the Department of Health. And this includes adding methadone on the essential medicine list and ensuring uninterrupted access to OST. Even now, during a transition period, moving on to GC7, we have to ensure that there is no interruption when it comes to methadone access to our clients. Also, access of methadone within correctional services to provide treatment to this highly vulnerable population. Second to that is invest in a holistic person-centered care. I've mentioned it. It's also in the evaluation findings that we have to move beyond this biomedical model of care, and we have to take into consideration the importance and the value of psychosocial support services when it comes to harm reduction integrated care. Your mental health screening, your economic empowerment program, your skills development program, your programs for young people, your programs for parents who use drugs, because they are also parents and they deserve rights and access to children like we all would. So ideally, this will address the root causes of substance use and support long-term recovery as beneficiaries identify these as crucial needs in their journey of stability when they are on OST. We also need to expand the access and reduce the barriers, so scale up on service delivery through increased mobile outreaches, and which we've seen in the Global Fund NACOSA program, where we've implemented a decentralized model when it came to OST. So taking the services to the clients. Transport as part of the evaluation was the issue. You take services to the client, you extend clinic hours, and you be strategic in your take-home dosage when it comes to stable clients. And this really is crucial to overcome key barriers, as I mentioned, lack of transport, distance to clinic, conflicting work schedules. And we found that even when clients are on OST, they're stable on OST, and then they find employment, they find it difficult to come to the clinics to get their doses. And this ideally will improve your overall retention in the program. And then combat stigma and build capacity. So implement a mandatory anti-stigma training, particularly for healthcare workers and law enforcement, to ensure that we have a dignified and supportive environment for people who use drugs. I mean, we've been saying this for a long time now, that it's not just providing the treatment, the training. It's about ensuring that the training that is provided is carried out by healthcare workers and law enforcement to prevent our clients from feeling stigmatized. Also, I think it's about investing in continuous training and practical training when it comes to working with people who use drugs, as part of a mentorship that will provide healthcare workers and law enforcement. And then lastly, it's just to secure sustainable and cost-effective funding, which we've all been talking about. And I think this program in particular, as well as the COSUP model, demonstrate clear value for money. We have policymakers and donors that need to prioritize our sustainability within South Africa. And that is for long-term funding for OST. This includes exploring public healthcare partnerships using programmatic proven data, and we have the data to show it, and that to show, the uptake on ART, the uptake on DAAs for hepatitis C positive patients, the uptake, on TB medication, clients being virally suppressed, to reduce, number one, your risky behavior, and to really just to advocate for domestic health budget allocations. Thank you so much. I will end my presentation here. Thanks, Yolande. Thanks so much, Yolande. Good morning, good afternoon, everyone.
Thanks, Kalvanya. And just to say that I think that we haven't even done justice to this evaluation in this 15 minutes. There's so much more to unpack. And once again, a thank you to Sadiba Hope Medical Center for the amazing work that they did, but also to the partners, as well as implementing organizations that inform this evaluation, and most importantly, to the people who use drugs community, who were involved in the focus group and survey discussions. As I put in the chat, Sadiba Hope and NACOSA will be at INSU, the International Conference on Hepatitis and Substance Use, that is happening in October the 14th to the 17th of October in Cape Town. So it's really exciting to have it in Africa this time around. And we will be presenting on several aspects related to this evaluation, but also on other aspects of our programming for NACOSA, specifically on overdose, on decentralization of hepatitis services, on human rights work that has been done, as well as on the parenting program that Kalvanya will also be presenting on at INSU. So Kalvanya, I see there's one particular question, or maybe two, one specifically from Sally. Kalvanya, what is the main barrier to the integration of opiate substitution therapy? Is it mostly related to budget, or is it related to political will or policy deficit? What is that main barrier to the integration of OST?
So I'm assuming, Sally, that integration into public healthcare services, and I think it's twofold. It's political will, number one, if anything, but also the fear of the unknown. And I think that, this evaluation has provided a good platform to allow Department of Health, healthcare professionals to really dive into OST service and to explore the avenue of OST services. And I think that there's a lot of education and training that needs to be done even at a primary healthcare level in order for this to be adopted into a public healthcare environment.
Thanks, Kalvanya. Another question from Etienne, if I'm pronouncing the name correctly. While there is a policy and legislative support for harm reduction at national level through the National Drug Master Plan and the Prevention of and Treatment for Substance Abuse Act, are there any legislative barriers to integrating harm reduction into primary healthcare facilities at national level? So they're not, I think they're referring also to opiate substitution therapy because that is a harm reduction, but I also assume that perhaps they're referring to needle and syringe programs as well at primary healthcare level. So Kalvanya, is there perhaps any legislative barriers?
Not that I'm aware of, Yolan. I'm also going to be guided by my human rights colleagues on the call. But from my understanding, there's no legal barriers that will prevent access to needle and syringes, except if it's a cost factor coming from Department of Health in terms of the commodities that are provided by donor-funded programs.
So just colleagues on the call, there is no legislative barrier to providing needle and syringe programs at any level, including primary healthcare. In actual fact, the provision of needles and syringes is in response to the constitutional right to healthcare. So there is no legislative reason why not. Drugs is criminalized, but needle and syringes is not criminalized. In regards to the opiate substitution therapy, there is no legislative necessarily barrier. However, I think Kalvanya did mention that we need to look at the essential medicines list and see where it is placed and if it is allowed within primary healthcare facilities. For instance, hepatitis treatment is currently on the essential medicine list at tertiary level, but not necessarily at primary healthcare level. And so those type of factors need to be looked at. Kalvanya, I would like to ask you to look at the questions perhaps in the chat if there's others, and please respond while we move on to the next presenter. But thank you again, Kalvanya. I do notice that there is a hand up. Perhaps we can entertain this hand, Kalvanya. The hand is from Luhwani. Luhwani, you are welcome to unmute and ask your question before we move on to the next speaker. Can we just, there we go. Over to you, Kalvanya.
Yeah, thank you. Thank you very much. My name is Libuwani Nemutenga. I'm from the health department in the city of Tshwane. We are working with the University of Pretoria to implement what we call a community-oriented substance use program. So in many instances, when people interact with the program, they always say, for example, I had it here to say, Dr. Bhoora from COSUP. So actually, COSUP is not an institution, but actually a program. But She is from the University of Pretoria, working with us as the city, being the funders. But I wanted to speak on the issue of the impediments to both OST and needles and syringes. My observation is that there's lack of trust in those with authority and anyone who is not in the space on the effectiveness of both solutions, whether OST is working, whether people are being relieved, whether people can get better. The questions that we get to be asked: who have you treated? Who have you made to no longer use substances? Show us the people and all those things. And what is the value of all that you are doing? So that shows that there's no trust or there's lack of information in terms of the effectiveness of the programs. So it is very, very difficult. And also the other point that we have observed ourselves is on the issue of registering in line with the Act. The act that we use for substance response, the one that is regulated by social development, that is implemented by social development, and the expectation that as a service provider, you need to be registered in line with the requirements of the Act. And where we are implementing these interventions as health services. And I just happened to listen to Judge Cameron when he was in one of the programs this week, and he said, I think the best way might be that we should treat this response as a public health response than dealing with the fight against drugs. Thank you.
No, thank you. I think those are critical points, is that too many times it is seen as an issue related to one group where actually it's not. It's related to public health and it's related to public safety. So thank you so much for those valuable inputs. And just noting again, for those that are able to go to the chat, you are welcome to do so, and we'll have the speakers respond or answer your questions in the chat. Over to our next speaker, who will be calling out loud a call of action and presenting on the call for expansion of harm reduction and opioid substitution therapy services in South Africa. We have Reginald Kgoedi. Reginald is a dedicated community advocate for the people who use drugs sector. He has been instrumental in empowering the P-word sector through strategic initiatives and collaborative efforts. He co-facilitated harm reduction training sessions, contributing to the development of a strong grassroots-led people who use drugs sector. Participating and advocating for the P-word sector independence within the SANAC civil society forum structure, participated in the submission of the harm reduction component within the National Drug Master Plan, and currently he's the project coordinator for Mpumalanga Provincial Institute of Civil Society Organizations, people who use drugs sector national deputy chairperson as well. So welcome, Reginald, and welcome for your inputs regarding the P-word subsector or the P-word sector's call for action. Reginald, over to you.
Good day, colleagues and partners, and the opportunity to speak on this evergreen subject within our country. Thank you. Comrade colleagues and researchers, as we may know that South Africa is experiencing a rising prevalence of drug use, particularly opioids, your heroin, your tick, your cannabis, and the crack cocaine. And this use it's mostly concentrated in township, informal settlement, rural areas, where unemployment, poverty, and social exclusion worsen the vulnerability. It becomes more seemingly of a social entertainment at some stage. An estimate of more than 10% of the population use illicit drugs in our lifetime. This you can get it from Sakendu, your UNODC, HR, HSRC, report. As a result, this perpetuates infectious diseases, overdose, death, and stigma and discrimination amongst people who use drugs. And currently, the health and social consequences are very, very severe, particularly for youth and people who use drugs. Hence, the call for intervention of harm reduction and OST services. And despite, the evidence that Kalvanya highlighted and COSUP, harm reduction in OST, it's very cost-effective, life-saving, and right-affirming. Coverage remains extremely limited and unfunded due to relying on the international donor. Next slide. Why I'm saying we need also to understand harm reduction. I know we spoke about harm reduction and OST, but now we thought I wanted to bring it not from the scientific approach. Hence, I'm saying without dwelling more into scientific approach, harm reduction is more than a set of health intervention. It's a social force rooted into in human rights and social justice, as it drives by the socio-economic and political will. Most of our speakers, I think you hear them, they're speaking much of more about the political will. Why? Because our government signed the treaty. However, when it comes to implementation, they are very, very, very reluctant, particularly in the space of DOH and DSD. Hence, we say the strategies here in terms of harm reductions aims at minimizing the negative health, social, and legal impacts associated with drug use, focusing on practical solutions rather than solely on abstinence. The OST, of course, they spoke about it, but in our case, we look at the treatment method that involves providing patients with a substitute medication such as methadone and propanate to reduce withdrawal symptoms and cravings associated with the opioid dependence. Now, issues of policies also comes in, policies and regulations that govern health practices, services, and interventions, particularly in relation to drug use and harm reduction initiatives. These, forms, components of the entire harm reduction, but not excluding the community-based intervention vis-a-vis also the scientific approach. Of course, programs and initiatives that engage local communities in addressing substance use issues through education, support, and access to services. Hence, it is important not to focus only on implementation of science. It's not the only, it's only one piece of the implementation puzzle. So in South Africa, you look at CBOs, peer networks, and policy are the main drivers of implementation success in health and implementation science. Of course, implementation science plays a supporting role in the whole system. Next slide, please. The evidence and the impact, I'm not going to dwell much into that because Kalvanya spoke about it. This data from the 8 districts of 52 districts shows that with the right tools, strong partnership, and sustained investment, we can change the course of national health, human rights, and economic justice for the better. Of course, using community intervention. So it's very important, as Kalvanya indicated, the pros and cons, the evidence, the importance, and the success. The findings that, she indicated really from the slides that we got from SANAC BBS slide and the KPOP survey from almost 6 to 7 provinces actually demonstrate the evidence and impact and successes that harm reduction is very important. But despite, these evidence-based solutions being available, access to harm reduction and OST services remain extremely limited, reaching only a fraction of those in need. It's a very, very, very small fraction. And this figure shows that we must move very fast and proactively so to reduce, the fragmentations and eliminate, distractions, discrimination, and make it easier for all relevant, parties to work with us. Looking at this data and the evidence and the impact, it actually tells us that the substance use treatment and harm reduction services are very essential component and comprehensive strategies, for reducing the harms of the drug use and overdose. However, these services have been historically in isolation, particularly in our space, in South Africa, and it hinders progress. So there's a need to better understand how these programs and can serve people who use drugs and integrate it into the services. Can I go into the gaps in South Africa slides? Now, you look at the whole presentation that makes by other colleagues. It tells us the researchers from COSUP, NACOSA, THC, and RHI, including Sanput. We find that only about 5% of people who use drugs or inject drugs are receiving OST. NSP operates in 11 districts out of 52 districts, and of which you'll find that only 8 districts are actually implementing OST. So in South Africa. So out of the 36 needle and syringes per person per year are distributed, which is far below the UN guideline. And now methadone and naloxone are also very, very expensive and not accessible in South Africa, which limit the public sector intervention. However, to achieve this, we need to make an advocate, or we need to engage the act, to release, and minimize and the rescheduling, which we'll talk about it when we get into the call for actions. We also have the extremely poor or no integration of harm reduction services and OST in the public health facilities across the country, apart from NGOs that through, of course, your PEPFAR, which is an international donor, your Global Fund, but we don't have such domestic funding to ensure that this kind of services is provided. So NGOs are playing a very, very major role in providing or the harm reduction services and OST within the our public space. And you look at also the National Drug Master Plan, it's really, we've been having the review and participating and engaging, but still it exists at a high level policy framework, at a high level, but provinces and districts still lack the synergy and the alignment, including the operational plans. They don't even have budget, they lack even the accountability mechanism, that include also your bylaws, in which perpetuate the legal barriers. So the OST and the NSP relied more on international donor, as I indicated earlier, and we don't have domestic funding apart from Tshwane through COSUP, which is the only role model that we need to piggyback on it and learn from them as to how did that municipality came about. And we don't even have the no proportionate or balanced representations of the PUD on substance use structures to influence these laws and policies. Hence, we find a bit of a resistance in most of our structures, particularly in the provinces and the district from other provinces. Can we go to the next slide for call for actions? Now, we felt the need that we need to urgently call, for the national scale up of OST, to, they highlighted it from the COSUP perspective. Kalvanya also spoke about it. to integrate, the primary health care, to integrate it into primary health care, and also district, clinics and hospitals. Also increase funding for harm reduction services, which we have tried, particularly within the global fund space, but unfortunately, due to reprioritizations and the likes, and the stop order, we found ourselves having to go back again to square zero. That will actually might have helped, to scale up, NSP, and also the rollout of the naloxone. And we need also to do the peer outreach. Is very important, and the establishment of the community advisory group in various districts and provinces, and also and overdose training, which we have quite a number of overdose fatalities, but they are not registered because of when a person passed away, the postmortem is not conducted. Now, policy reform, we feel that we need to proactively and aggressively engage into the decriminalization of drug use to enable health-based responses. These also include to address laws that disproportionately impact on women, particularly women with child. We understand that women on child custodies and they are getting also harsh sentencing. So women who use drugs, they're really not in a safe space within our space. We need also to assist them. And I'm happy with the program that NACOSA came up with that will actually empower women who use drugs to understand their rights. And that will actually bring them into having, the capacity to understand the harm reduction and what is actually due to them within the public space, and also to take, health services. We need also, as a sector, to encourage our partners and peer-led networks, to aggressively go all out in training and capacitating the healthcare workers, the justice systems, and including the communities around harm reduction. And it's important, as we indicated when we talk about harm reduction, that it's not only science approach, but we need also to look at the socio-economic perspective of harm reduction. And now also the PWOD leadership and participation, we need also to ensure a meaningful involvement in program design, because as I indicated that, in most provinces and districts, when you present the harm reduction, you seem to be, closed out. There's no room for you to come in and participate, particularly in decision making and in programs development. And that therefore means by doing that, we're able to accelerate programs, particularly the program of Know Your Rights, targeting at women and our youth. Now, going back to the review, which is paramount important. Kalvanya also touched on it, which is very important, because we can't move particularly into decriminalization if we don't start from this angle of reviewing the acts, prevention of and treatment of substance abuse, and drugs and drugs trafficking act, the Medicine and Related Substance Act. This act, the act will able to assist us to improve access to treatment and provides for more registration of establishment of treatment centers, particularly including the drug consumption rooms, which will able to run for 24 hours, and ensuring that people would have an access to essential services and including shelters. So, this act and regulations are actually playing a very pivotal, strict, role in the regulations and the bureaucratic, process which limit the availability and accessibility of OST and NSP services. So by removing of these strict regulations and bureaucratic processes, it will able to that limit availability and accessibility will scale up the OST and NSP services, including the rescheduling of methadone, naloxone, and other medical treatment that may assist with the side effect, because they are all governed by this act that need to review. You look at it, it's I mean, you have the Medicine and Related Substance Act number 101 of 1965. Where are we now? We are now almost in towards 2030, but still subscribing to an act that doesn't speak to this generation. In our conclusion is that harm reduction and OST are evidence-based, cost-effective, and humane, as they indicated when our other presenters were presenting their findings, which actually demonstrated, the success of harm reduction and OST, and also, we scaling up of these services. It's a public health imperatives and a human rights obligation, not an event to tick the box. Like what is happening, particularly in the public health space. Having events that doesn't actually make impact on the ground. They just tick the box. One other thing is the commercializations of funds. From those who actually receive funds in the name of the key pops. Once they get the funds, they started to be very, very, arrogant, even turning to forgotten that they're just grant administrators. That will not, with that kind of an attitude, is not going to assist us to expand harm reduction services in South Africa. Instead, it will invalidate all the good work, that is done by our community-based organization, your NACOSA, your COSUP, SANPUT, and the PWIT sector leaders from various provinces. So we need to work together to ensure that health, dignity, and inclusion for PWIT in South Africa, it's actually honored. So having said that, we invite government, particularly DOH, DSD, the justice clusters and the donors, the private sectors and civil society organization to partner with the PWIT sector in expanding the harm reduction and OST across the provinces. So the PWIT sector, SANPUT and its networks, including TB HIV care, NACOSA and SANAC, are very, very good players, to identify, patterns and offer guidance to help the system to perform better. However, in some other instances, they get marginalized, which causes the problem to continue with this scaling up of the harm reduction services. I'll later continue, Yolande. Thank you very much.
Reginald, thank you so much. And just to say that the work that we have managed to do with our implementing organizations could not have been done without the strong support from the South African Network of People Who Use Drugs, as well as from the PWIT sector over the last few years. I think it's a lesson for all that these type of partnerships and also giving the opportunity for the voices of the people who use drugs to be able to be given a space is critical to drive change. So thank you for your leadership, Reginald, and for your support throughout this program. Reginald, we have gone over time and I'm asking the guests for their allowance, but I just want to ask you one particular question before we move on to closing up. What is the role of decriminalization of drugs for personal use, what role will decriminalization play in seeing the expansion and uptake of, harm reduction services and opiate substitution therapy?
Once it's decriminalized, it's going to play a major role into the users, particularly, the dignity of the users will be restored, discrimination will be restored. And I mean, this will also deal away with discrimination, the stigma, and also it will also particularly those who are incarcerated, they're able to participate in the economic space, because currently with these criminalizations, some, once you get into the space and you are registered within the justice system or the judiciary systems, you are unable to get an employment because now you are a criminal, so it's criminalized. So it's going to change and empower people who use drugs also to use drugs in a very, very responsive way. Unlike, when you take something, from, an element of inferiority, you get to overuse and exploit it. But once you are given the opportunity to use it at your own will, you're able to have, a personal management on the use of anything that you might have, including the drug use. Thank you.
Thank you so much.
I'm having another meeting. I'm joining another meeting.
Thank you so much, Reginald,
1:30,
for your time. You're welcome. Keep well. So,
Thank
colleagues,
you.
as we're busy wrapping up, just to mention that NACOSA has a podcast. It's called the Say It Anyway, the NACOSA podcast. It's about real voices taking the mic. No jargon, no judgment, just raw, honest conversations that bring hidden perspectives into the light. From untold stories to everyday experiences, it's like a kuier, a visit with an old friend who isn't afraid to ask the tough questions. This is a podcast about people, their lives, and the stories that shape our communities. You can access it on any podcast channel that you use, including iTunes, Spotify, and the NACOSA YouTube channel. So please sit back and enjoy the introduction to Say It Anyway, the NACOSA podcast.
Anyway, the NACOSA podcast.
Hi, we're NACOSA, and we have a podcast, the NACOSA Say It Anyway. NACOSA is a networking civil society organization that's been around for a very, very long time and has done amazing work in the sex work space, community system strengthening, adolescent young people, and also in the people who use drug space. And we're really, really proud of this podcast. A lot of hard work has gone into it, but also we've had some really good partners that have come in to provide the valuable input into topics that are not easy. So we hope you enjoy this podcast. It's really about issues that nobody's talking about because nobody wants to raise awareness around it because it's so conflictual. So yeah. So anyway, guys, I think that we'll just move on to who it is really for. Over to you, Cal.
The podcast was designed for a broad audience, but primarily targets the community, substance users, and advocates. Its core purpose is to provide a platform to open and honest conversations about topics that are often considered taboo or difficult to discuss, especially for people who use drugs. Say It Anyway often features real stories of people who lived experiences and people who work in the forefront of harm reduction.
So our podcast is called Say It Anyway. And we're just so proud of the work that we've done. And we want to bring these people on to talk about their raw and unfiltered stories, because it's really stories that you don't hear about. And it's stories that our communities don't know about. Things like harm reduction. Does your aunt know about it? So we're bringing those people in. We're bringing in parents. We're bringing in the youth. And we're just opening the conversation. So it's to all of you. Just join us.
Additionally, the topics that we are looking at, this theme, the topic for this theme for now is parenting and drug use. As the group have shared, not many people speak about these. The upcoming topics that you have to look forward to would be things like gender transformative issues, sexual reproductive health issues, gender-based violence and femicide, and also other interesting topics like drugs and disabilities. Please join us. Thanks.
Thanks so much. And as we have the chat link to the podcast, Say It Anyway, really proud of this work and hope that you will find the time to listen to the 4 episodes around parenting and drug use. We now will close off this webinar, and very sad for me as your moderator is this is actually the last webinar of the series of the Amakazi series. We have presented or had 5 webinars so far, and the first webinar was actually on young key populations. And there are particular key learnings that we had. We had presenters from the UWC Public Health or School of Public Health. We had students of Sensible Drug Policy International, SANAC, as well as a presentation from NACOSA's Human Rights Program. In terms of the UWC, I mean, the key issue was around adolescent boys and young men. Where are we going wrong by not prioritizing programs for them that focuses on gender transformation and gender equality conversations with these adolescent boys and young men so that we can see changes in the gender-based violence incidents? With students with sensible drug policy, it was related to the access of needle and syringe programs for minors who use drugs. And then for SANAC, it was about talking about, giving civil society an opportunity to be part of the conversation, to inform policy and program gaps. And then for NACOSA, it was pure and simple. How we are talking about policies and programs, but it's not progressive enough to actually deal with constitutional rights. The second webinar was regarding the decriminalization of drugs for personal use as well as for sex work. And we actually had quite a few, respondents in that webinar that called for either decriminalization of some drugs or at least equal amount saying all drugs. And then obviously people saying we need to have a much more human rights approach in terms of the discussions around sex work and drug use. In terms of Sesonke, their personal focus was on sex workers' legal protection and their rights, and that by decriminalizing, we were allowing them an opportunity to access services and resources for that legal protection. For Lawyers for Human Rights, their focus was what is the legislative and policy reform changes that need to be made to shift us from a criminal punitive program to a more public health and social harm reduction initiative. The third webinar was a very good webinar that was very close to my heart, which dealt with, the human rights experiences and gender-based violence experiences by women who use drugs, as well as the queer community. And, Sanpo did a particular presentation about, needing to achieve good health and practice harm reduction for women who use drugs. You need to reduce the stigma and discrimination that affects them accessing those services. With the Lesbian and Gay Community Center, the fact is that they are more likely to disclose and be cooperative in spaces that are supportive of diversity and expression, and that also there are too few international and domestic resourcing for LGBTQI programming specifically for queer female communities. For Open House, their call was around change in language and decentralizing post-violence care to community hubs that also focus on social and psychosocial wellness and safety. The fourth webinar was around human rights violations experienced by people with disabilities, and particularly key populations with disabilities. Our South African Human Rights Commission presentation was talking about needing to strengthen implementation and enforcement of disability rights laws and enhancing private sector accountability in employment and inclusion. The Department of Social Development talked about silos and breaking down those silos, not only amongst sectors, but also amongst government departments. And SANAC spoke specifically about, once again, not pushing policies and programs without the voices of those most affected being included in that conversation. And then today's webinar, as you've had with our amazing speakers from NACOSA, COSUP, and the PWID sector, is saying, you know, programming for opiate substitution therapy and harm reduction is possible if one has champions within the public sector that recognizes the merits and find means within the municipal budgeting to make this happen. NACOSA specifically saying is that we need to integrate this and that we need to expand it by investing in a holistic person-centered care program that is also cost-effective. And the PWID sector notes that without recognizing decriminalization of drug use, it will negate the integration and expansion of harm reduction and opioid substitution therapy within all settings, including primary healthcare facilities. Once again, colleagues, thank you for your patience and sticking around for the last few minutes. I would like to conclude by saying that we want to thank our translators for sign language and French interpretation from Happy Clouds that has been on this journey with us and that has made this webinar much more accessible, especially for those that are hearing impaired or deaf. We also like to thank the technical team from Slack Activate who have led us on this journey of webinars as well as the podcast development. We could not have done it without them. And then speakers from COSUP, NACOSA, and the PWID subsector, thank you for your valuable time. And once again, we want to thank the VIV Healthcare Positive Action Program grant because this webinar series would not have been possible without that support. And once again, from the NACOSA team, thank you so much for your inputs, your attendance, and we hope to carry on this conversation with you in various platforms. Good day.